Thank you very much, Liz. Yes, I must admit, I walked into this session and read the title of my talk and had that sinking feeling that you had when you were talking about exam questions at the end of the exam, then you realize you've just answered the wrong exam question. So I, of course, blamed Daryl for giving me this title and then didn't read the actual session title. So I apologize, it's not quite. Well, I will wing it and try and answer the title at the same time. More pressure because, in fact, I'm not meant to be the person giving this talk. It is, in fact, the very famous, very, very famous Ken Hillman, who has written a lot and talked a lot about end-of-life care, and I think will be instrumental in making many changes across the acute care system in terms of dying in acute hospitals. So I did have a quick listen to the podcast that he and Charlie did with Geraldine Doogue at the weekend. So hopefully what I might say might not be too dissimilar to what Ken might have said. But anyway, so I'm sorry to disappoint you on 2 accounts already. Now, yesterday there were 3 of us who had the same quote. And I put it up again, so if you have got that bingo sheet ready, we're now filled in the 4th box. So, but I think it's very pertinent when we're thinking about end-of-life care that really what we need to always remember of how we manage end-of-life care, particularly in the acute care sector, is really obviously about the patient experience, but is their families, their caregivers who walk out of the door finally for that last time, and that memory will be with them for a very long time to come. And it is often their stories that are now being told to politicians of how we as healthcare professionals really need to step up in this space in terms of end of life and how we manage it. So we do need to give it some thought, I think. So what I'll try and do is set the scene, the national scene, and then my 5-point plan. And then as an addict to that, as I'm winging, I will give you the top 5 tips of how to perhaps look at improving end-of-life care in your own organization. So hopefully that will be of some help to you. But as we know, and you've seen this graph a few times now, is that dying occurs in a variety of ways. But it would be fair to say that I would imagine the most common situation is that when a patient dies in an acute care hospital, it is not a surprise. If it is a surprise, then something has gone wrong. So I would think that we're going to knowingly not to be surprised when patients die. So we need to, I think, step back a bit and think, well, if that's the case, why do we keep leaving everything that we do in terms of comfort care, withdrawal of acute treatment or intervention to the last 48 hours of their life? It's just, I find that surprising. That's not to say I'm not guilty of it, but I do all think that we all need to take that step back and think, what are we trying to achieve here? So as I say, dying does occur in various ways, suddenly and gradually, with chronic disease, frailty. But at the end of the day, when patients come into hospital, their last hospitalization, I don't think many of us are surprised that they have died. So the challenge we have is if we look at ourselves as a community, apparently, although I'm not sure at the reality end this is actually what we would want, 60% of us would want to die at home. What happens, though, is because we fail to make plans, and that's only 3% of those that are dying, or I should say 11% of those of us dying in the hospital, 3% in intensive care who die, have an advanced care plan. So we're not telling our families what we want at the end of our days, and so what happens is that 60% of us land up dying in an acute hospital. And that then means that because we haven't got a plan at the beginning, we haven't spoken to the doctors don't speak to you, then a lot of us will either get admitted to intensive care units, so between 20 and 40% in acute hospitals around Australia, you will die in an intensive care unit or have had some experience of intensive care in your last hospital admission as your last experience of life. So a lot of us are facing the critical care teams, be it the MET or intensive care, as we die. And then because of the resourcing issue, we very rarely engage palliative care. So only 40% of deaths in acute care hospitals will see a palliative care doctor or a nurse. So again, when we do see them, again, it's very much in the last 2 days. We all seem to be in a big rush right at the end, instead of thinking, well, actually, you know, life is a journey, and probably if we're not surprised that they're going to die, do we not need to engage palliative care earlier on? but the resourcing then becomes an issue. So what happens is there's this big tension between what we can do, because it's often easier to do something than not to do something. And to not do something, you actually need quite a bit of clinical experience. And what do we do in hospitals? Well, 70% of the week, if we think of it Monday through to Sunday, the 24/7, 7 days, 70% of that week is run as an out of sort of hours system. So very junior doctors, very junior nurses, and inexperienced, so that they cannot make these decisions of not doing something. So they'll do it instead. So there's a big tension that we all face. So then there's the challenge of, well, how do we, even if we're not going to do something and allow people to die without sort of being symptom-free, because there are many burdens that we then have to sort of get rid of to allow our patients to have a good quality end-of-life experience. So the best thing to do for patients is making sure that they are spiritually, have a sense of spiritual peace, that we reduce their burden, and that we engage their loved ones in a meaningful fashion. And the difficulty always is visiting hours, clocking in and clocking out, and so loved ones aren't actually even welcome in many situations. So actually to honour and provide a good quality death is very difficult in an acute care hospital, which is not set up, certainly at the moment, to deliver, I think, high quality end-of-life care. And so what happens is that patients lose their dignity because we do all sorts of horrible things to them, particularly at the end. They have a loss of sort of meaning to life. They have no purpose. And so this is all becoming a very miserable experience. And then this real sense of burden that the patients carry because they're either burdening the healthcare professionals, they're a burden to their family, and really, therefore, they're starting to think, well, really, I don't want any more life and we need to get rid of it. So I think this doesn't create for a very good, high-quality end-of-life care in the acute care sector. So I guess that's setting the context. So we prefer to die at home, and yet we're dying in acute hospitals, and acute hospitals are not set up. So how can we make it better? Well, I guess if you're thinking about how do we make it better, we need to focus on quality of life. And how would we might do that in the acute care sector? We need to decrease suffering. And so I guess minimizing the symptoms that they might be exposed to. And then bolstering their sense of meaning and continuing this sort of self and role preservation, that they're real people sitting in or lying in their bed. And then maintaining their pride and hopefulness. But being realistic at the same time. And then reducing the aftermath of concern so that there is a plan after they have died, what might happen. So these are things that we probably need to focus on, but again, in the acute care sector, it's very, very hard. So the 5-point plan, I think, is more about, how can we best deliver a good and high-quality, sort of safe end-of-life care. And then we'll talk about, well, how do we, as an acute care sector, actually look to deliver this 5-point plan? Now, I don't know what Ken's 5-point plan would be, but this was probably what I would have a stab at as being the gold standard. Not to mention the Australian Commission on Safety and Quality in Healthcare have got their national consensus statement on end-of-life care. But 5 big-ticket items. Well, the first thing is, and I think this is now sort of talking to ourselves as a community. I guess if I ask the audience, how many of you have spoken to the people who are important to you about what you would like, the values that you would like as you approach your end-of-life? How many of you have actually spoken? Okay, and so keep your hand up. How many of you got it written down? So a few, 2, 3. So not many of us have spoken about what we want, and certainly very few of us have actually written it down. Now, I'm not saying writing it down is probably the way to go. I mean, that probably would be at odds to some people's thinkings. But it is important to make a plan, and that's obviously pre-hospital. Give your loved ones an idea of what it is. Paint a picture. What does it look like? What does the journey look like for you? And everybody will be different. The difficulty, as I said, is that not many of us are writing these plans down. So if you look at the stats, certainly when we looked at 1,700 patients who died across 9 hospitals, only 11% had actually got a written plan prior to entering hospital. That's not to say that we then also can help that process by, I guess, looking at patients who may not survive, at least that admission or maybe the next one, what the goals of care should be for that patient on arrival. And again, we need to look about who's making or having those conversations. So very few of us are writing plans, but I think it's something pre-hospital we need to think about, and certainly when the patient hits hospital, we need to think about what does their picture look like, and may need some understanding from the family, the patient, and the usual caring doctor. Because if we don't understand, then it makes it very hard to plan ahead, which of course is not happening at the moment. So make a plan. Now, if you're making a plan, you need to tell someone. So it's all very well having it written down on a piece of paper, but if it's the solicitor's office, that's not a very handy place out of hours. So you need to tell someone that's going to be around when something happens, or at least so you know who to locate, and that you need to trust them. You need to trust them that when you lose the ability to make decisions, you're actually going to entrust them with the decisions that you think you would like. So tell them someone you trust. So I would probably prefer, not prefer, but I think one of the ways of doing plans and telling someone is that it's not so much looking at the written document. I don't know how many have actually been exposed to dealing with the written document, but I've never found it very practical. But tell someone that you trust, and then we have this sort of in-the-moment decision-making. So that when, as a clinician, I'm talking to the family member, that actually they are aware of the patient's values, what's important to them, what will matter to them at the end. So you have that conversation. Now, if you have looked at Saul's talk on the TED Talks, he talks about, I think you need to entrust, if you have a daughter, apparently you're very lucky, because they're the people that you can trust. And if you're actually hearing Charlie Cork on Saturday, he also said the same thing. He's entrusted his daughter, not his wife. Apparently his wife would never withdraw any kind of treatment on him. So if you have a daughter, that's great. So I think you need to find someone who's, A, going to still be alive, and the second thing is actually then, they're going to be reasonable. Okay, so now we've talked about making the plan, and we can certainly do that as they come into hospital. But if you're making the plan, you need to tell someone. It's a bit like the organ donation story. So then the thing is that you need to recognize dying. Now, I would imagine what happens is when you ask someone, can you recognize dying, the answer will be yes, because seeing that last gasp probably is quite recognizable, such that the cleaner or untrained eyes can spot it. The difficulty I see is it's not so much the actual dying process, it's coming upstream and I guess having a think about, well, is this patient going to survive the hospital admission, or does this life expectancy look like less than 12 months? That's probably what we need to be thinking of. Now, there are tools out there that can help you understand whether the patient's unlikely to survive. Again, I guess it's not so important about the prognosis or accuracy of that prediction, but the broad ballpark of do you think they're going to survive the next 12 months? You need to start having that goals of care conversation. What's going to be important to them? What are the things they would like? What are the things they would not like? Do they want a medical emergency team coming out and rushing? So there's lots of tools that we can do. SPIT, there's the gold standard framework, and there's the AMBER tool from St Thomas's in London. And I'm sure there are many, many more. But what it means is you're putting a system in place to trigger the conversation so that you're recognizing that this patient is at risk and would benefit from having a goals of care discussion. And then, of course, this is the Crystal tool that Ken Hillman and his team designed. Again, it's trying to work out who is not likely to survive the hospital admission. I mean, none of these variables are rocket science, and I guess it's really endobetogram that may suggest to you why you should be having the goals of care conversation. So say it's not, I don't feel it's actual predicted to die, but actually are they sort of vaguely in the ballpark that we need to have that goals of care conversation. So the conversation becomes critical. And the difficulty I have is that you need to be a skilled communicator. And having a one-off workshop, whilst it's very good, and I certainly at the ANU Medical School, all our students will go through some sort of breaking bad news conversation workshop and other sorts of workshops. But if you then don't practice that conversation, which are often very hard and change in terms of context, then you're actually not going to be very able to communicate in a way that's understandable so that the messaging is clear. But you need to be able to communicate to the patient who's dying, if they're still alert enough, and to their families, and be very clear about it. But because we run this out-of-hospital, sort of out-of-hours system, when you look at those 1,700 deaths that we looked at in the 9 hospitals, you can see how many people are having that conversation. A, it's a lot, and B, it's spread across all sorts of disciplines. But what's, I guess, important is if you look at the home team consultant or the home team junior doctor, it doesn't it really is just mirroring the in-hours, so 30%. So really what we're looking at is who's there in the hospital at the time to have the conversation. So it doesn't mean that we need to still conduct this process, that everyone is trained up, or do you start to think, well, do we need pockets of people who are very good at having the conversation? But then, of course, it comes back to patient ownership. But whatever we do, we need to make sure that when we're having an end-of-life care conversation, that it is meaningful. And then I guess the next thing we need to do is looking at initiating how we might then manage the end-of-life care itself. So going back to the conversation, it needs to be clear. It needs to be an honest conversation. And you can start to judge whether people are receiving the information meaningfully, or you need to stop and come back to the conversation. And of course, you need to be respectful. And obviously, patients and families will have different, values and meanings. So again, you need to adapt the way you speak. The importance, and in fact, only yesterday we're seeing that having silence as part of your communication strategy is very important. So when you're delivering the so-called bad news, there's often a moment when you should pause and allow that information to sink in and then restart it when you feel that the family are ready. So it's really listening more and talking less. So the other aspect is that we need to think about is once we've had the plan, once we've recognized that they're dying, training someone that you trust and communicating properly, is that once we're going down the pathway of the actual active dying process, then we need to be very clear about relieving symptoms and providing dignity all along the way. And sometimes that's very hard in the hospital environment. So relieving symptoms, you would think, as I mentioned before, that you would engage palliative care, but only 40% of the time in the hospital environment do we engage them, and rarely in the intensive care unit. We do not consult palliative care. That's not to say we don't initiate the so-called comfort care we do in the intensive care unit, but we certainly don't do it through a palliative care process. And I guess, what's happening, though, this is all right at the last minute. So even though we think they're going to not survive the hospital, everything happens within the last 48 hours. And even within that 48 hours, 60% of patients will get some sort of active intervention or investigation. So I guess I would question whether right now we're doing the right thing. So I guess in summary, as I mentioned before, these are the 5 big dot items I think we would need to do to make our end-of-life care as best as it can be. So that said, then how do we as acute care hospitals then make sure that we're delivering the best end-of-life care? So I guess the first thing you need to do, and I'm surrounded, I imagine, by critical care healthcare professionals. You need to find someone in your hospital who's a clinical and believable and credible clinical champion. So you need that person to drive change. And I would recommend that it's not an intensive care doctor, because we're seen as a doomsday doctors anyway. So trying to find someone who will push this as a thing that we must improve. You need to give executive buy-in. Without having executive buy-in, you will make no changes, or very hard to make change. You need to gather data, and I guess that's where the Australian Commission of Safety and Quality in Healthcare has now got this toolkit for measuring the dying process. Now, the big trouble is we're missing the patient experience, and I guess that's something we all need to work through, as to how do we measure the patient and family experience. That's something not to be ignored. But you need data to say where in the process of dying are we not doing well. So for example, in my own institution, we've measured 4 disciplines, and each of those disciplines are different in the way they manage their end-of-life care, such that one discipline, 50% of their patients have a MET call prior to death, and 50% of those MET calls, they will actually die at the MET call. And this is a discipline where they have a very good predictive tool of dying. So data, I think, are incredibly powerful in persuading people that things need to change, but identifies the gaps. So the clinical champion, the data, you then need resources. And there's no doubt in my mind that the third aspect, you need a project officer, which of course means resources, but with the meaning that you're going to look at improving the way we manage end-of-life care. So the project officer will then engage, obviously, a working group that can give face validity to the intervention that you then design. Now, interventions here could look like end-of-life care, that you must have a goals of care resuscitation plan. So very clearly articulating what it is, what happens when the patient is dying. So that needs to be worked through with the patient and the family so that there is that shared decision-making. Things you could also look at intervening is a communication and making sure that those that you think are going to have the conversations are actually trained up. And I guess the third aspect is, when the patient's actively dying, that you're actually monitoring that they are symptom-free, that the patients and family are having, I guess, as good an experience as possible, and you're monitoring that. And that's quite then good for evaluation post-intervention. So then once you've designed your intervention and how you might implement it, you then would do a pilot. Personally, I would be doing pilots on high-risk wards, so that the discipline that I just spoke of, we're working with those clinicians and seeing how we might implement in that particular area with the data that we have had previously. And then having trialled it out in a pilot area, we would then promulgate it against the hospital, making sure that there were governance systems in place. So in summary, I guess my 5 top tips for good end-of-life care is that you know what end-of-life care, a good quality end-of-life care should look like, and then you might talk about how you might then align your own organisation, where are the gaps, and then how might you make changes along with it. Thank you.